All right, everyone, welcome back from lunch. I have the pleasure of introducing our next speaker. Dr. Michael Davies is an assistant professor in the UCSF Department of Orthopaedic Surgery, specializing in sports medicine and shoulder surgery. He provides care to patients at both UCSF and Zuckerberg San Francisco General Hospital. Dr. Davies' clinical care focuses on complex shoulder and knee problems, along with common sports-related injuries affecting patients of all ages and athletic levels. Dr. Davies earned his Bachelor of Science in Biology from Stanford with distinction and departmental honors. Dr. Davies is one of our own. He earned his Doctor of Medicine at UCSF, then completed his orthopedic surgery residency in the UCSF Department of Orthopedic Surgery. Then he went on to fellowship in sports medicine and shoulder surgery at HSS in New York, where he served as an assistant team physician to the New York Knicks and the New York Liberty. Unfortunately, he was already back in San Francisco when the Liberty won their recent WNBA title. In addition to his clinical practice, Dr. Davies is an accomplished researcher. His research focuses on the role of stem cells in tissue regeneration, with particular applications to rotator cuff injuries. He has been recognized with numerous prestigious awards and grants for his work. I am excited to have Dr. Davies present on this topic, specifically for you today, as he has been instrumental in helping us reduce barriers for our PlaySafe program student athletes to seek specialty care at Zuckerberg San Francisco General Hospital. We are thrilled to have him as one of our team physicians at Lincoln High School and supporting our incredibly diverse athletic population in San Francisco. Please join me in welcoming Dr. Michael Davies to present to you on health disparities in sports medicine.
Thanks so much, Gina, for that very kind introduction. This topic today is a little bit different than the basic science talks that I'm usually giving, but I really appreciate the opportunity to be here today and talk about this very important topic that I'm passionate about. So I have no commercial disclosures that are relevant to this talk. I do want to give a big shout out to Dr. Nirav Pandya and Dr. Jeffrey Kwong for their contributions of some of the slides for this talk. So to begin, we'll review some key definitions that allow us to move this conversation about health and healthcare disparities forward. We'll then discuss the ways in which health and healthcare disparities are present in our field of sports medicine with a focus on patient outcomes. And finally, I want to spend some time towards the end highlighting areas for intervention that we should all consider in our clinical practice to help address this unsolved problem in our field. So in order to create change, you have to understand some basic terminology. And this is a really great JBJS review article by some of our UCSF orthopedic surgery faculty, which highlights the broader impact of disparities in orthopedic care as a whole. And I highly encourage those of you who are interested to find and read this article. But one of the key takeaways from that article is that it's really essential for clinicians to know how disparities affect our patients, as the effect of health and healthcare disparities can play a big role in patient outcomes, and as big of a role, in fact, as our surgical interventions or our post-surgery rehab do. And that's a really sobering realization when you think about it. So first, we need to distinguish between what we mean by the health of the individual versus the health care of the individual. The health of the individual in the context of health disparities is defined as a higher burden of disability of one group compared to another. Another way of looking at this, according to the Centers for Medicare and Medicaid Services, is as preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health, health equity, or health outcomes experienced by disadvantaged populations. In contrast to that, healthcare disparities can be defined as differences in access to care or quality of care that can't be explained otherwise by other factors. And this is really where, one way in which we come in as healthcare providers is considering how delivery of care can be impacted by a number of factors. So, it's really important to take a step back and remember that in our society, the delivery of healthcare is affected by numerous factors, including race and ethnicity, sex, gender identity, and sexual orientation, socioeconomic status, insurance status, and even neighborhood and geographic location. All of these things can play a role in the delivery of our healthcare. And the consideration of the ways in which healthcare is affected by these factors brings us to the important concept of social determinants of health. So social determinants of health can be defined as conditions in the environment where people are born, live, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. This diagram sums up some of the core social determinants of health, including economic stability, geographic environment, education, social and community context, and health and healthcare status. All of these things can really play an important role in terms of how patient outcomes are achieved. So in a way, you can think of these social determinants of health as a root cause of health and healthcare disparities, which ultimately may lead to differential health outcomes among different populations of patients. So with that basic terminology out of the way, now it's time to consider some examples within our field of sports medicine and really see how these things play out. We'll begin by looking at an operation near and dear to every sports surgeon's heart, ACL reconstruction. So this first study that I wanted to touch on was a meta-analysis published by Dr. Chris Jones, who's the team doctor for the LA Lakers, and his colleagues, looking at epidemiology and outcomes around ACL injury and ACL surgery on the basis of gender and race. And they found that there is a higher rate of primary ACL injury in females, but males undergo higher rates of ACL reconstruction surgery. Males also happen to have a higher rate of return to sport after surgery compared to females. With regard to race, they found that white patients are more likely than non-white patients to undergo ACL reconstruction. They also found in their sub-analysis that compared to other races studied, Black and Hispanic patients experienced delays in time to surgery, were more often lost to follow-up, and had access to fewer PT sessions post-operatively compared to the other groups. And going back to gender-based disparities, they also found that males displayed higher functional outcome scores following ACL reconstruction compared to females, and females demonstrated decreased extensor strength at 1 year after surgery. With regard to timing of surgery, non-English speaking patients had the greatest delays in time to surgery of all groups studied. And just as white patients were most likely to undergo primary ACL surgery, white patients also most commonly underwent revision ACL surgery compared to non-white patients. So, race and gender aside, it's also important to consider the impacts of insurance status. And this is a study that was carried out at UCSF by Dr. Pandya and colleagues, which looked at the impact of both insurance status and race on access to care for pediatric and adolescent patients with ACL injuries. And what they found here was that in the case of insurance status, patients with public insurance waited significantly longer, both before they could get their initial MRIs after their injury, and also between getting their MRI and having their surgery. So there were essentially two different lag times there. And in this cohort of patients, when a multivariate analysis was performed comparing groups by race, which in this study was defined here as white versus non-white, and insurance status, which was defined as public versus private, the authors found that insurance status was the major driver of delays in time to surgery. So you can see in the Kaplan-Meier plot pictured here that there are really two clusters of groups among the four groups being compared, and the major variable which seemed to dictate the time to getting surgery here was public versus private insurance. So in other words, both white and non-white patients were waiting significantly longer to get to surgery if they had public insurance compared to private insurance. On the other hand, that's probably not the full story. Other work has shown that race is in fact an independent factor for delays in care for ACL injuries, even when controlling for insurance status. So this was a study out of HSS in 2020 in which the authors performed a multivariate analysis of both race and insurance status and looked at the mean time that it took to get patients with ACL tears to the OR after injury. And what they found was that for both public and private insurance, Black and Hispanic patients experienced greater delays in care compared to white and Asian patients. So race is clearly a very important factor here, and it's important to ask ourselves, is racism, or at the very least unconscious bias, playing a role in these findings here? So now we're going to move from the knee over to the shoulder and take a look at how these variables affect shoulder instability outcomes, as this is another very common injury that we see in our clinics. And just like ACL tears, the timely management of shoulder instability is very important in preventing worse damage from occurring to the shoulder. So this was a retrospective study looking at how likely patients are to receive shoulder stabilization surgery after going to the ER with a diagnosis of shoulder instability. And there were really two trends which the authors noted here, which reflect what we previously saw with ACL surgery. Black and Hispanic patients were less likely to receive shoulder stabilization surgery compared to white patients, and patients with Medicare and Medicaid were less likely to receive surgery compared to privately insured patients. This study sort of looked at things even downstream of insurance status to really consider how patients present initially to clinic. So in other words, how many dislocations have they had, what condition is their shoulder in, as a function of whether they had Medicaid versus other insurance types. And the authors here found that patients with Medicaid presented initially with a greater number of events and greater bone loss. So here, insurance status was essentially directly linked with the severity of the pathology that patients were initially coming into clinic with. And this is a big deal when it comes to shoulder surgery because it can dramatically alter the kind of surgery that you're going to get. So if you come in with a torn labrum in your shoulder, but minimal glenoid bone loss, you may be a candidate for an arthroscopic repair of your labrum, which is a minimally invasive surgery with very solid, predictable outcomes. If you present late to clinic with severe bone loss in your shoulder, you may require a much more invasive open surgery, such as a Latarjet, which has a much higher complication rate compared to an arthroscopic stabilization, even though both are fairly predictable at actually stabilizing the shoulder. Another common shoulder condition that we frequently see in our clinics is frozen shoulder or adhesive capsulitis. So I wanted to take a look and see how health and healthcare disparities may play a role in the epidemiology and treatment of this condition. In this case control study of over 2,100 patients with adhesive capsulitis, racial minority status was significantly associated with being diagnosed with frozen shoulder, along with obesity and diabetes. And in many cases, frozen shoulder can be managed non-operatively with PT or with steroid injections, but in the most severe refractory cases, surgery is sometimes required to release a tightened capsule. And so this study also found that the patients who were most likely to receive surgery for adhesive capsulitis were young, white, and workers' comp patients compared to all other groups. Moving on to another very common condition that we see across our clinics, meniscus tears. So this study aimed to look at what is the trend between race, insurance status, and access to surgery when it comes to meniscus surgery. And this was a review of an insurance database looking at over 32,000 patients. And what they found was that female gender, non-white race, and public or self-pay status were associated with lower rates of getting meniscus surgery. This was another study among young athletes showing that patients with public insurance or who are uninsured experience significant treatment delays compared to those who are privately insured. And just like in the shoulder, this can have a really significant impact when it comes to whether we are able to repair a meniscus tear versus whether we have to trim out a substantial portion of the meniscus. So in this particular study, they were looking specifically at patients who presented with bucket handle meniscus tears. So these are tears in which a large piece of the meniscus is flipped within the joint. And frequently, we tried to repair these tears if they present early enough, because the alternative is sometimes trimming out a very substantial portion of the patient's meniscus. And in this study, they found that uninsured or underinsured patients had a greater time to surgery compared to insured patients in the setting of presenting with a bucket handle meniscus tear. Ultimately, there ended up being similar rates of meniscectomy versus meniscus repair between these two groups. However, they did find that presenting within 6 weeks of injury was a very strong predictor of having a meniscus tear that was repairable as opposed to one that had to be cut out. So, the timely manner in which we can get patients into clinic really matters in terms of the surgery that they get and outcomes. Moving on to perhaps the most common condition in the shoulder that a lot of us see, the rotator cuff. This first study was looking at the effect of specific social determinants of health on access to care for patients getting rotator cuff surgery. The authors found that patients with lower socioeconomic status, public insurance, or low-income zip codes were treated at low-volume facilities by low-volume surgeons. And I probably don't need to tell you that there are plenty of other studies in the orthopedic literature that show that, yes, operative volume and surgeon experience does tend to correspond with better outcomes across a lot of other studies. Now, this was a study then looking at access to PT between privately insured patients and those with Medicaid for following rotator cuff surgery. And what they found was that patients with private insurance were given much more rapid first appointments and had more facilities available to them to choose for PT. And this was a somewhat creative study related to insurance status in the setting of rotator cuff tears, where the study coordinators called 71 different orthopedic practices in the state of North Carolina about a fictitious patient with a rotator cuff tear. And they made up one scenario where the patient was said to have Medicaid insurance. And in the second scenario, the patient was said to have private insurance. And they recorded how frequently the practice would agree to see the patient. And they found that 72% of patients offered, 72% of practices offered the patient an appointment when they called and said the patient had Medicaid insurance versus 96% of the practices who accepted the patient with private insurance. So we've talked about some major variables so far with regard to access to care, which include race and insurance status, but obviously it's even more complex than that. And here's some other variables and examples of how access to care can be affected in subtle ways. So this was a study looking at racial bias in sports medicine staff's perception of others' pain. So this was a group of NCAA Division I medical staff who were presented with experimental vignettes about a student athlete with an ACL tear, and they were asked to make inferences about pain. And the study found that participants perceived Black subjects as having a higher initial pain tolerance compared to white athletes. And inferences like this, which may be rooted in unconscious bias, can affect access to care and undertreatment, and can ultimately result in underdiagnosis of injuries that are perceived to result in less pain initially. Less accessibility to athletic trainers at the high school level can likewise be another facet of access to care that affects patient outcomes. So this was a study looking at schools with and without athletic trainers, and they found that those without athletic trainers were more likely to be in counties that had lower median household incomes or have more students who are eligible for a free or reduced cost lunch compared to schools that did have athletic trainers present. And then moving on to another commonly treated condition in our field, concussion. This was a very important study looking at the self-reporting of concussions by athletes and found that when it comes to concussion treatment, Black athletes were less likely to report their concussions to the athletic training staff than white athletes. And the authors found this likely stems from inequities in resources related to concussion education among student athletes. So all of this is honestly a very sobering look at how health and healthcare disparities affect our patients with many of the common conditions that we see in sports medicine. But now I want us to turn our eyes onto our own workforce and see how things are looking on the horizon. So this was a recent study done looking at the demographic breakdown of U.S. medical students, orthopedic residents, and sports medicine fellows by sex, race, and ethnicity. And you can see each of these different graphs represents the percentage of a particular demographic across these three levels of training, so medical school, residency, and fellowship, between 2013 to 2022 based on nationally available data. So you can see that starting out with the graph that looks at participation of women across these fields, you can see that when it comes to medical students, women went from just below 50% of constituents to above 50% over this time period. In orthopedic surgery, they increased in representation from approximately 14% to 20% by 2022. However, the proportion of women in sports medicine has hovered at close to the 10 to 11% mark over the entire time period. And I should specify this is sports surgery specifically, not primary care sports medicine for this study. The results for the other groups are even more sobering. While Hispanic representation increased in medical schools over the time period, it decreased in both orthopedic residency and in sports medicine fellowship between 2013 and 2022. Black representation in sports medicine likewise decreased from about 5% to 2% between 2013 to 2022. Asian representation in sports medicine has oscillated over the years, but went from around 16% to around 5% in the same time period. And white representation increased from 77% to 85% over the same time period, even while showing a slight decrease at the med school and orthopedic residency levels. These are the participation to prevalence ratios for male and female sports medicine fellows, as well as sports medicine fellows by race. So a blue bar basically means that there's a ratio greater than 1, meaning a greater concentration of individuals from a given group are participating relative to their national representation of that group. So by that measure, you can really appreciate here just how underrepresented women are in sports surgery, in addition to non-white and non-Asian racial groups. At the attending level, this was a separate study that sought to look at the percentages of female and URM physicians in leadership roles within sports medicine. Between 2010 and 2019, the proportion of female orthopedic surgeons in sports medicine increased from 5% to about 6%. And only 3.3% of leadership positions in sports medicine, as defined by this study, were held by female physicians. Now, it's a slightly brighter picture in primary care sports medicine currently. In this survey, women represented 25% of the physicians surveyed, and there were no significant differences in academic rank looking at academic primary care sports medicine physicians between male and female physicians. There was also significant representation of female PCSM positions in leadership roles within major academic societies as detailed in the table. So you can see that those percentages ranged anywhere from 41% up to 78%, depending on the different academic societies polled. So clearly, based on all this data, we have a very long ways to go within our field. And so the final part of this talk, before we really open things up to discussion, is to really ask, what can each of us do to help? So I think the first step is just acknowledging the scope of the problem that we have within our field. Disparities exist within this subspecialty that we all love so much. It's important to provide care that is patient-centered and culturally competent. Part of that is understanding the biases that exist in our society and within healthcare that result in race, sex, gender, insurance status, and socioeconomic status being factors that end up dictating health outcomes. And along those lines, we can all make use of resources such as the American Medical Association Health Disparities Toolkit to help recognize our own knowledge, assumptions, and biases about patients. Further, it's important to train staff and fellow physicians within your group to be culturally competent and to understand that preconceived notions of patients can affect their outcomes. It's very important to ensure that language isn't a barrier to obtaining care, making interpreters readily available and using them with great frequency. And it's important to provide educational resources that keep our diverse audience and our patient populations in mind. It's important to support and volunteer in initiatives that advocate for workforce diversity, such as the Gladden Society and the Ruth Jackson Society. And it's important to commit to seeing under and uninsured patients. We can work with PCPs and community health centers to help troubleshoot issues of access to care for patients, including things like authorization and making sure that our front office staff are educated on easing access issues for patients with Medicaid. And we should really be collecting data on our own patients and looking at our own outcomes based on different demographic factors to see if there are differences in outcomes among our own patients, and if so, asking ourselves why that's the case. And then when it comes to advocating for youth sports participation, it's important to ensure that finances are not a barrier to sports participation by encouraging youth recreational programs. So before we open up to questions, I'll end this with a reminder of the differences between equality, equity, and justice. It isn't just enough to give someone the same supports. Even with equal supports, someone still may not be able to see past the barrier in front of them. By giving everyone the supports that they need, then we have an equitable situation where everyone can see over the particular barrier. But obviously, the ultimate long-term goal here should be, of course, to remove the barrier in front of everyone, and that's the justice that we ultimately strive for. Thank you. And again, special thanks to Dr. Pandya and Dr. Kwong, and happy to take any questions at this point.
Are there any studies being done that look at how individuals actually perceive pain in their culture and injury in their culture? Because as a physical therapist, that's what I see. Mm-hmm. There are differences that are inherent to their culture on how they are perceived if they're hurt, what role they have in their family, what role they have in society, even their way out of, their life, wherever they are, and they're trying to get somewhere. And so sometimes they're not saying things because they know if they admit that they're hurt, they're not going to get a shot at something else. So they're not going to tell you.
Yeah. I think that's an extremely important point, and I think that that's probably something that's under-researched right now. This area of healthcare disparities research, I would say, has really kind of exploded over the last 10 to 15 years, but I still think that taking into account, individual communities and individual cultures when it comes to perceptions of pain is something that we're probably not looking at yet, but really should be.
I never found this study, but I've heard about it. It's a study with humerus fracture. They compared opioid use Vietnamese versus, American. It was something like 10% versus 90% post-op use of opioids. 10% of Vietnamese use about 90%. I think that's
Yeah, I think there's pain perception, there's, response to just even being given medications, whether or not you want to take the medications that are prescribed to you or not. I think all of those are really important factors.
I have two things to comment today. I just think that some of these statistics that you present have so many factors involved with them that it's hard really sometimes to make judgments based on just race. Just as, for example, some of the statistics were based on our pediatric population and based on race, when they were going to get in to see their physician. And I just don't know if, there is a societal difference in, white families versus black families. And we can say that it's based on race, but it's also based on, do they have two parents? Do they have one parent? There's so many variables that to describe it to race, I just don't know how you do it.
Well, this is where I think the concept of social determinants of health really comes in, because that is kind of the idea that this is more complex than one single variable, and there are many different variables that probably contribute. But unfortunately, things like race, sex and gender identity, all of these are sort of easier to put into categories for statisticians, which may be why a lot of those studies rely on those variables heavily. Certainly you can do things like zip code to look at neighborhood. You can do, you can find proxies for a bunch of different social determinants of health. I'll certainly admit that the methodology of some of the studies isn't perfect, but I think when we see these differences come down to variables like race and gender, we really need to be asking ourselves why that is, even though it may be more complex.
Can I make another comment? The other thing is about diversity in orthopedic surgeons. And, you know, as a specialty, as a surgical specialty, I just don't know how, you know, women are treated in that specialty. And whether it has to do, because, I mean, I don't know if people are aware that in 1976, Congress passed the Health Manpower Act that prevented residencies. They said that residencies have to offer part-time positions. And I think that was mostly based on the idea that women were not, you know, if you were in a surgical specialty and you wanted to have a child, you know, you weren't considered part of the program. And now they're considering it, you know, and this is 1976, so I don't know if people are still using that law to prevent programs from discriminating against women who want to have a family and children and continue in a surgical specialty that, you know, can be prolonged for 10 years if they're deciding to have a family.
I'm sorry, I'm not sure I totally understand the point of the question.
Well, the racial, the gender disparity in orthopedics may be due to underlying prejudices against women having families, and whether that is still going on in terms of manpower, in terms of residencies offering part-time positions.
I see. I mean, I'm not aware of any residencies in orthopedics currently that offer part-time positions. But
it's a federal law. You have to offer part-time residencies.
I mean, I do think that there are, you know, extreme barriers for women entering the surgical field, even to this day, and a lot of it, unfortunately, has to do with just prejudices of the past, I would say. But a lot of programs are certainly focusing on how important it is to reach more equity when it comes to women in orthopedics, and I think that's a driving force behind a lot of the residency programs currently. But I agree, there are still some barriers that are present that may not be as easy to see.
Dr. Davies, there's a couple in the chat for you. As a surgeon, what are the most important takeaways for your post-op patients with limitations in transportation and support at home?
Yeah, so I think planning ahead is really one of the biggest things. So finding out what patients' resources are and are going to be after surgery ahead of time. I've had patients at San Francisco General who we find out at the last minute that they're actually out of county. And so, they can get their surgery done at the General, but then setting up physical therapy afterwards is going to be very difficult to do at the General. And so that just takes, more time on the back end to figure out how this person is successfully going to get to their therapy sessions after surgery, participate in that, have access to an adequate number of PT sessions in order to have a good outcome. Otherwise, why are we doing the surgery?
Is that an insurance issue? You said they're out of county.
It can be, yeah.
Because if they have regular insurance, then they should be able to transfer from county to county.
Correct. So a lot of times it is with our patients who are underinsured. Yeah.
I think it's probably the biggest issue here.
Yeah. And that is a big recurrent factor in a lot of the studies that we've seen.
Another one for you. What do you see as the greatest challenge to young female athlete training that may lead to inequities in motor control and higher ACL injury rates?
I think, first of all, it's an under-researched area. I mean, I think that studies kind of looking at female landing biomechanics compared to males, these are things that were done, 10 to 15 years ago, but not before that. And so there's always a lag time between understanding differences in underlying biomechanics and muscle firing patterns before you actually get to the point that you have established rehab protocols. So I think there's probably been a lag time in coming up with the right rehab for individuals and for young female athletes compared to just kind of the standard rehab that maybe was being done in male athletes for many years.
have another question. How do you, none of us have enough time, and really digging into social determinants of health takes time. So how do you grapple with trying to figure out what of that is the most important within your scope of what you're doing for the patient?
Yeah, I mean, I think, it's going to vary by individual patients and also by the practice setting in which each of us is practicing. So for me, for example, at San Francisco General, I do think that there are real delays in care that can happen for our non-English speaking patients there. And so really just working on the end of getting reliable and readily accessible interpreter services is huge. But that's just one population that I treat. I think it may be very different, on an individual basis. Great. We're wrapping up a little bit early here, but thanks so much, everyone, for joining and for your participation.